So David, KRAS clearly has become more relevant in terms of informing us on treatment decisions, and certain data that has emerged over the past 6 to 12 months has certainly altered how we think about this. But perhaps the development of these drugs is predicated on a better understanding of KRAS tumor biology. Now, we know a lot about this over the years, but certainly as new therapies become available, we've learned more. So can you briefly walk us through kind of high-level overview of KRAS tumor biology, 101, if you will?
Okay, 101. I think the first thing to say is that KRAS was the first mutation identified in cancer, and clearly the first oncogene, the first driver. So if we go back to 101, we have oncogenes and we have tumor suppressor genes. I love the analogy about oncogenes being your foot is stuck on the gas, yeah, and tumor suppressor genes are you have brakes, and when you lose the tumor suppressor gene, you have no brakes. So the worst situation is to have an oncogene and loss of a tumor suppressor gene. Your accelerator is stuck on the floor and no brakes. That being said, KRAS is an oncogene, which is a driver. It's associated with increased proliferation. And it specifically undergoes a transition alternating between GDP and GTP. When it's in the GTP state, it is on, and it's on all the time, and it drives the growth of that tumor. So the second thing to mention is that not all KRAS mutations are the same. Yeah. The worst KRAS mutations tend to be transversions versus transitions. Those transversions are the ones associated with tobacco carcinogenesis. G12C fits into that. And we'll come back to that more a little bit later.
Yeah. So talk about, that is a nice 101 overview I like the analogy between the tumor suppressor and the foot on the gas approach when describing this. Can you talk a little bit about some of because KRAS signaling is complex, and some of the downstream signaling that occurs when KRAS is constitutively active, because this lends itself to, I think, prior therapeutic approaches to exploit KRAS lung cancer, some of the pathways involved downstream.
Yeah, so again, before the recent advent of the small molecule inhibitors, which directly inhibit KRAS, one approach was to go after the downstream pathway, since you couldn't inhibit KRAS by itself. So that's the MAP kinase pathway, that's RAS, RAF, MEK. So there are several targets there where we've had drugs that are direct inhibitors before we had these new direct inhibitors of KRAS. So these are all genes which are associated when they're mutated with a proliferative state, again, oncogenes, and they are all downstream of KRAS. So once KRAS is on, these other genes become more important.
Yeah, the downstream signaling approach, I think, was initially promising with some of these MEK inhibitors, and we can talk about this maybe later, but certainly didn't pan out in a phase 3 fashion, at least in a refractory setting. Certainly MEK inhibition seemed promising. It still may seem promising for future, but at least combined with docetaxel, it didn't seem to provide a better outcome specifically for KRAS.